Assalamu alaikum and welcome to our lecture on vulval cancer. In this lecture, we want to understand the prevalence of vulval cancer and how it changed in recent years, discuss diagnosis and management, and understand treatment options and their advantages and disadvantages. First of all, let us look at prevalence and risk factors. Prevalence of vulval cancer is rare. There's about 2.5 in 100,000 new cases each year, so you can understand how rare it is. It is mostly a disease of older women, but recently we found that there has been an increase also amongst the younger women, and this is due to an increase in HPV infections among this group, as well as an increase in smoking. So this figure kind of shows the number of cases per year according to the age. So the age is on the x-axis, and you can see that there's an increase with age, and that really there's very, 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 very rare cases are only found in the younger women. This is another picture that shows you the rate per one. So this shows the rate of vulval cancer per 100,000 women according to age and at different times. And you can see again that the rate is the highest in those that are over 80, and a significant decrease is between 70 and 79, and in the very young women the rate is very low. So risk factors are age, a history of VIN, HPV infection, as well as chronic inflammation of the vulva, and this is mostly in form of lichen sclerosis or lichen planus, smoking, and immunodeficiency. Those are the main risk factors for vulval cancer. Here's another figure that shows prevalence or age-adjusted prevalence of different HPV-associated cancers. You can see the blue line, the most common HPV-associated cancer, especially in the younger age groups, is cervix carcinoma. But this is then followed by vulval carcinoma, and this is in the red line. And you can see how this, with age, eventually actually crosses the cervical cancer line, and you can see a higher prevalence than cervical cancer in the older age group. Vaginal cancer is a very rare illness, and you can see it, a very rare disease, also most commonly found in elderly women, and you can see it at the bottom of the graph in green. How does vulval cancer present? Mostly it presents with the women themselves noticing a lesion on the vulva. This could be a lump, it could also be an ulcer. It can just simply be a change in the vulva, such as a pigmentation, a thickening, or whitening. So it can sometimes present in the initial stages quite not so obvious, quite subtle. Sometimes there's associated pain or vulval bleeding and ulceration. There might be burning, soreness, and itching. So it might present actually very similar to VIN, and just with the eye, it's impossible to distinguish just with from VIN. The only thing that you can say is that there's a lesion which is abnormal. Here's some examples of smaller and larger vulval cancers and how they presented at the first presentation. This is a very advanced vulval cancer, which shows a typical kissing lesion, where you have the larger lesion from the patient on the patient's right, which is quite large, and this has caused an opposite lesion because the labia majora sit together like that, and it's called the kissing lesion. So what have you got to do to diagnose vulval cancer? When you can't distinguish it with the naked eye from VIN, you have to do a workup of this patient. So first of all, you want to know a little bit more about the history. You want to know what the presenting complaint was, the duration, associated symptoms. You want to know about urinary symptoms, a history of vulval disorders such as lichen sclerosis or VIN. Cervical smear history is important in this context, as well as previous surgery, past medical history, and drug history and allergies are always important. Then it is important to examine the lesion or the area carefully, and this is important in any patient who presents with vulval discomfort, vulval itching, or tells about a change in the vulva. It's not good to just say, "I'll try this cream and come back," or "try this cream and go away and don't come back." You have to look at the vulva to evaluate the vulva so that you can see what she is talking about. And this it involves looking at the vulva, but it also involves a speculum examination to visualize the cervix, because, as we said before, VIN and CIN are associated. And so you can find sometimes if women notice changes in the cervix, you can also see in the vulva, you can also see changes on the cervix. The anal and perianal skin needs to be evaluated, and a detailed documentation needs to be done of the lesions, of their size, of their location, and of their kind of appearance. Photo evidence is most helpful in this circumstance. Finally, you have to take a biopsy of the lesion. Without biopsy, you do not know what you are dealing with exactly. So any suspicious vulval lesion needs biopsy, biopsy, biopsy. The biopsy has to be taken at least 1 centimeter deep so that you can do adequate staging with it. In some cases, you need to take multiple biopsies. If you have multiple lesions, you need to have multiple biopsies. And as I said before in the previous VIN lectures, these biopsies need to be numbered and described for the pathologist. They need then to be put on a kind of a drawing to kind of exactly know which number belongs to which location. So this means they have to be orientated, so the pathologist just knows the location, and also you know the location. This you have to keep this in the notes. Histologically, most vulval cancers are squamous cell carcinomas, but you find also very rarely a malignant melanoma. After all, this is skin. You have to remember this is skin. So you can find any skin disease also in the vulva. So you might find malignant melanoma. Rarely you find basal cell carcinoma or extramammary Paget's disease, which is an adenocarcinoma in situ, and Bowen's disease can also be found in the vulva. In the vulval cancer is rare. 5% are associated with positive syphilis serology, and others might be associated with lymphogranuloma venereum or granuloma inguinale, which are tropical diseases, tropical ulcerating sexual transmitted infections, actually, which are more common in parts of Africa, in the tropical parts of Africa and Asia. It is important to do a good staging before you plan treatment. It is very important to do good staging. In order to achieve good staging and plan the treatment well, you have to, from the outset, discuss and treat this patient with a multidisciplinary team. This has to include a gynecological oncologist, a gynecological pathologist. It has to include a dermatologist who has experience in this area, and of course it might often include also a plastic surgeon. So the stages are according to the FIGO stages. Stage 1A the tumor is less than 2 centimeters and is still confined to its original location. Stage 1B, the tumor is, or the mass or the lesion is smaller than 2 centimeters in diameter, but it has not spread. It has not spread from its location, but it's deeper than 1 millimeter. So this is important, 1 millimeter, because the risk of lymphovascular space invasion of the tumor increases significantly if the deeper the invasion goes, and above, if the tumor is less than 1 millimeter, there's a very, very small risk of lymphovascular space invasion. However, if it's deeper than 1 millimeter, the risk increases a lot that the tumor might actually have invaded the lymphovascular space. And with lymphovascular space invasion, of course, you have the higher risk of lymphatic spread of the tumor. And this vulval carcinoma mainly spreads by local invasion and lymphatic spread of the tumor. Stage 2 is a tumor mass which is greater than 2 centimeters in size, and it might involve the perianal area, the vulva, or both, but has not metastasized in other areas. So here you can see 1A, less than 2 centimeters, stage 1B, more than 2 centimeters, and then you have stage 3, where you have a cancer mass which has started to spread to nearby organs, such as the urethra, the vagina, or the anus. And also it might have invaded lymph nodes on one side of the body. Stage 4A might involve lymph nodes located on both sides, so bilateral lymph nodes, the pelvic bone, or bladder, urethra, or rectum. And stage 4B involves distant parts of the body outside of the pelvis, but this is a very rare and very serious finding. You also find recurrent vulval cancer, and this is the real disturbing thing, that if that the treatment was complete and the treatment was the cancer was kind of removed as far as all clinicians could say, but then you find a recurrence of the cancer. And this is, of course, a very grave finding and very difficult for the patient to deal with. So this is stage 3 vulval cancer, where you have lymph nodes, and then you have, so you might have lymph nodes on both sides in small cancer, or a larger cancer and lymph nodes only on one side. You might have involvement of bladder, vagina, or anus. Tools for staging are of course biopsy, then CT scan, MRI, and chest X-ray. So, what is the management for vulval cancer? And you are right if you said that the mainstay of treatment is kind of surgery, but due to the fact that vulval cancer can appear in so many ways and forms and places, it needs to be a very individualized approach. So every patient has to have their individual treatment designed for them. You have to have a multidisciplinary team, including oncologist, radiologist, pathologist, and surgeon. And you want to remove as much tumor mass and bulk as possible, but as little as necessary. You might need psychosocial support for the patient, and this has to be assessed with individual cases. But if you have psychosocial support or not, these patients need a lot of support to be able to deal with this invasive cancer and this invasive kind of difficult treatment. Surgery needs to be planned very well, because you have to have appropriate surgery for the lesions. You might need to have to consult the plastic or reconstructive surgeon before the surgery, because if you have to do a vulvectomy or remove large parts of the skin, you need a plastic surgeon who can maybe do a flap and cover this, or a skin graft to cover this lesion. You have to explain to the patient very well what you're going to do and what her choices are. You have to explain also implications and available support. In early disease, it is possible to kind of improve the situation or to treat the tumor with a wide local excision of a single lesion. It is very important to be able to say that this lesion was completely removed. There has to be a 1 centimeter margin surrounding the fixated lesion. If you take a piece of skin and put it into formalin, the skin will shrink around the lesion. So therefore, when you excise these lesions, there has to be a 2 centimeter margin around at the time of surgery. If you then put it into formalin, you can be sure that there will be a 1 centimeter lesion around the lesion, that piece of lesion that you could actually see and remove with your eye. Lymph node dissection is necessary if the depth of invasion is more than 1 millimeter. The maximum diameter of the tumor is more than 2 centimeters. And then a triple incision technique where you make separate incisions for lymph node dissections on both sides reduces morbidity. Groinoid dissection is the greatest single factor in reducing mortality from vulval cancer. And this means to remove tumor mass and to remove cells that can potentially spread the tumor. If you can look at this illustration of the lymphatic system, you can see how many lymphatic connections there are to the vulval area and how they connect to the para-aortic lymph nodes in the end, and from there it can go everywhere in the body. So therefore it is important not only to treat vulval carcinoma kind of on time and well, but also to do the lymph node dissection in a kind of persistent and consistent way so that you can remove most of the tumor mass. There's of course a problem with lymph node dissection, and you probably know, you aware of this. It is of course lymphedema. Like a lymph node dissection in the axilla with breast cancer, lymph node dissection in the groin for vulval cancer can cause lymphedema, this time in the legs. And this is a very terrible problem. It kind of leads to the legs, affected leg or legs, to be very large and heavy, and can only really be treated by kind of graduated compression stockings, but this also is not that effective. So therefore groinoid dissection has to be done, is the single factor that reduces mortality, but also has got severe complications which can impact on the quality of life after surgery. Therefore it has to be done in a very kind of skillful way. Stage 1A needs no groin node dissection. In all other stages, groin superficial inguinal and deep femoral nodes should be dissected. Bilateral lymph node dissection is only necessary in central tumors, but if you have a lateral tumor, then you can do just ipsilateral dissection at the beginning. The new way of, one way of reducing the morbidity associated with lymph node dissection is to do sentinel lymph node dissection. Here you give patent blue or a dye or 90 technetium dye into the tissues surrounding the lymph nodes, and then you will see Either with patent blue, you can see it with your naked eye. With technetium, you will need kind of a nuclear medical kind of a scanner, and you can see if the lymph node is taken, if the tissue is taken up, or you can see that the lymph node that takes up this tissue. This is this dye. This is the sentinel lymph node. It is actually that lymph node where all kind of lymph nodes is collected at first, and from there it is sent to the other to the rest of the lymphatic system. Therefore, if you take out this sentinel lymph node, you have an idea if you can expect further tumor or spread into further into the rest of the lymphatic system. The sentinel lymph node is therefore dissected by giving patent blue or using technetium to kind of spread into the tissues, look where it is collected, and that lymph node is kind of taken out as a sentinel lymph node to see if there's any further spread expected in the lymphatic system. In some, sentinel lymph node dissection can only be done in appropriate cases. So if the tumor is less than 4 centimeters, if there's no clinical visible lymph node metastasis, and in unifocal tumors. In all other tumors, it should be the groin node dissection, the usual groin node dissection. But if you can, in those cases, elect for sentinel lymph node dissection, then you can reduce morbidity such as lymphedema and wound healing problems. Advanced disease needs careful planning for the surgery. It needs to include a plastic surgeon and needs to allow for reconstructive surgery to be done in the same sitting, so that you decrease morbidity from scarring and you increase quality of life later on. Surgery remains the treatment of suspicious groin nodes. And only women who are not well enough to have surgery should have radiotherapy instead. These are pictures from how surgery would look like. In the beginning, the upper picture shows you a wide local excision. It shows you a safety margin of at least 2 centimeters, so that when you put it into formalin, there's still a safety margin of a centimeter. The lower picture shows you a triple incision vulvectomy, where you have a vulvectomy of the area of the vulva, and then 2 kind of separate incisions for groin dissection, groin node dissection, and you can see how it ends up, what it looks like in the end. This is also a picture of a triple incision vulvectomy. So what complications are associated with the treatment for vulval cancer? So common complications are wound breakdown, wound infection, PV, DVT, and PE, because patients find it more difficult to move around because the area of the because also of the area of the surgery. You might find introital stenosis, often a lot of pain, lymphedema of the leg. Recurrences are a big problem here. Urinary and fecal incontinence might occur. An inguinal lymphocysts might occur, which are collection. They are not. They are pseudocysts actually, where due to the lymph node dissection, the lymph collects in the tissue around and gets caught in a pseudosac, in a pseudocyst. This can be very annoying. Sometimes you find hernias, and also you can imagine that the psychosexual impact is quite great after such a surgery. what post-operative treatment do you need to remember and do you need to give to these patients? Radiotherapy is an adjuvant treatment to surgery mostly. In some women who are too old for surgery, they just have radiotherapy, but radiotherapy on its own does not have such a, is not so effective for treatment of the tumor. However, some trials have shown that preoperative surgery to reduce the tumor bulk might, and then after that be able to completely resect the tumor at the time of surgery might work, but this is not yet final and still on trial basis. You also have to know that that surgery following radiation treatment is much more difficult and is prone to higher morbidity and more complications, as you have some changes in the area after the radiation therapy, and this might cause problems in healing, problems during surgery, and cause more problems on the whole. Chemotherapy is necessary in most advanced cases, in the inoperable ones, but also in those where complete excision is not possible or in those with metastasis. And here cisplatin is used, the same as also as adjuvant treatment in cervical cancer. It also uses cisplatin. Now, what is the prognosis of vulval cancer? And I can hear you all say to your computer while you're watching this, according to stage. And of course you are right when you say that. In stage 1, when you can do a wide local excision, actually prognosis is quite good. But in all following stages, it drops. Stage 2, still prognosis is relatively good, but stage 2, 3, and 4, prognosis is poor, as in all gynecological cancers. Recurrence is directly correlated to the size of the disease-free margin. Okay, so if you manage to excise the tumor with a margin of more than 0.8 millimeters or more than 1 millimeter margin, then your risk of recurrence is around 50%. But if the margin is greater than 0.8, so greater than 1 millimeter, you have a risk of recurrence of nearly 0%. So the risk of recurrence and also the risk of lymphatic spread is related to the risk for lymphovascular space invasion. A follow-up is very important. It has to be organized. There have to be regular visits to follow-up treatment, follow-up clinics for observation of the patient, but also for offering support. And as we said, there's a risk of recurrence. This has to also be addressed within the follow-up system. So after looking at this terrible disease, we can actually say that prevention is better than cure, and prevention should obviously be by HPV vaccination. Stopping smoking would help, and also taking note of changes in the vulva. So whenever there's a change reported to a physician, they have to have a look at it and take some action. If there's an early diagnosis or an early biopsy leading to an early diagnosis can make all the difference in these cases. If you have any questions now, please let me write them down and we can discuss them in our online forum.